Okay, okay. Huh.
Yeah. So good evening, everybody.
कशाला
On behalf of
introduction मी
Alkem,
काय विसरलोय काय
on behalf of Alkem, the fifth largest
आम्ही
pharmaceutical
मंदार आम्ही
company,
एकमेकाला विसरलेलो नाहीये
I welcome all the
अजून
moderators.
अल्झिमर सुरू व्हायला वेळ आहे
ते रेकॉर्डिंग आहे म्हणून ते रेकॉर्डिंग आहे म्हणून ते
हा मग ते
पालन
ग्लास घेऊ
करायचं.
नको.
बरोबर.
Let's
Go ahead, go ahead.
घेऊ नको. ग्लास
Mandar,
घेऊ नको.
Mandar, there is
काय
some
सांगतोय?
light
ते
focus
रेकॉर्डिंग
behind.
होते ना, रेकॉर्डिंग
Yes,
होते.
yes. It is. We are recording
अच्छा
it.
अच्छा
I
बरं मग ते
welcome
फास्ट
all
आटोपूया आणि
the.
मग नंतर ग्लास घेऊया.
ग्लास घेऊया. ग्लास भरणार कोण?
I welcome
बोला.
all the panelists
please.
as well as our moderator, Dr. Anand, for this views Vildagliptin panel discussion. We are very fortunate to have very, very senior physicians and diabetologists today for today's meeting. I will start introduction of all our panelists and the moderator. We are very fortunate to have Dr. Arvind Gongane as our moderator for today's session. Dr. Gongane is a very, very senior physician in Malad. He was the past president of Goregaon Medical Association as well as Malad Medical Association. He has been very active in API, IMA, RSSTI, and is a very astute clinician. Thank you very much, sir, for being our moderator for today's session and for accepting our invitation. Our panelists, we have 4 panelists today, and all of them, I don't think any of them need an introduction. They are extremely seasoned and very, very senior physicians. I will start with Dr. Kumar Patil. Dr. Kumar Patil is a very, very senior physician in Malad with almost 35 years of clinical experience. He's a very astute physician, and he will enlighten us today when it comes to views Vildagliptin panel discussion. We have other panelists today, Dr. Amit Trivedi. Dr. Trivedi has more than 30 years of clinical experience. He has done his MD medicine from LTMG and Sion Hospital, and his keen area of interest is chest medicine as well as cardiology. And he has been also in the practice almost for more than 30 years now. We have other panelists, Dr. Rajiv Tungare with us. Dr. Tungare also has been in practice for more than 30 years with a very, very keen interest in the area of diabetes and metabolism. Thank you very much, Tungare sir, for joining us today as one of our panelists. Our next panelist is Dr. Kirti Mistry. Dr. Kirti Mistry is a very, very senior physician in Kandivali West and is a proprietor of Kirti Nursing Home. Sir has passed out his MBBS as well as MD medicine from Grand Medical College and JJ Group of Hospitals. And he also has more than 30 years of clinical experience in practicing cardiology as well as diabetology. So with this panel in place, I am sure we are going to have a very, very fruitful evening on views Vildagliptin panel discussion. Thank you very much, sir, and over to Dr. Arvind Gongane for panel discussion on views Vildagliptin.
Thank you, Mandar, for your introduction. At the outset, I should say that I am with all my senior colleagues. They all are senior to me by age, experience, and practice. So here am I, a small man, just to ask my doubts, and I'm sure they are also experienced that they will clear all our doubts. So as our agenda today says that we would be starting off with the Vindagliptin. So first of all, the group of DPP4 inhibitors we should be talking about. So let's ask Dr. Rajiv Tungare, the senior man, about the mechanism of action of DPP4 as in whole. Just to give a refreshment to everybody.
We know that whenever we have food, the gut secretes some hormones which increase the secretion of insulin, and these are called as the incretins. And DPP4 is an enzyme which is present in the plasma, which destroys these enzymes, these hormones. They are GLP and GIP. These are the 2 hormones which are destroyed by DPP4 enzyme. So we have to inhibit this DPP4 so that the natural hormones which increase the insulin secretion will remain in the blood for a little longer time. So that way causing insulin release. So DPP4 inhibitors have come into play because they have an action, very important action of increasing the level of the insulin stimulating hormones uh, in the plasma. They also have an action of increasing, reducing the level of glucagon, which is a hyperglycemic hormone, which is a very important action in diabetes. Because we know that in diabetes, the level of glucagon may be high, and
That's
that
it.
can cause
I think this.
controlling that level will be giving us good control. Right. Thank you. Over to Arvind.
Glucagon secretion is reduced, no?
In diabetes, it is high,
Yeah.
and because of the DPP4 action, or rather the increased levels of GLP and GIP, the glucagon levels are also reduced. That way, the
Right.
sugar is getting controlled. Arvind has got three seconds. Hello.
Yeah, Arvind.
Arvinda's network issue.
Yeah, I think he has got a network issue, sir.
Yes. So we can
We
go
will
ahead
call
with
him
the
up.
second
We will call
question.
him
Yeah,
up.
we can go ahead with the second question, which is
How Indian
to
are
be,
different from others?
yeah,
Response to DPP4.
very interesting question. Amit,
Yeah, there
please
is definite
enlighten
evidence.
us. Hmm.
Yeah, there is a strong evidence that Indians respond better to DPP4 inhibitors as compared to Caucasians and Europeans. The exact mechanism is not known, but there are certain postulations. One of the postulations is that DPP4 inhibitors receptor, there is an overexpression of DPP4 receptor in the Indians and Asians, and thereby there is an increased DPP4 activity. So when the Indians are put on DPP4 inhibitors, they respond more aggressively to DPP4 inhibition, and thereby they bring about a good glycemic control. Another possible effect is that Indians have, as we all know, more of a visceral obesity. And this visceral obesity acts by reducing the insulin secretion. So Indians basically have more of an insulin secretory defect as compared to the Caucasians who have more of an insulin resistance. So this by improving the insulin secretion by DPP4 inhibitors, they have got a better effect. Another postulation is that there is something called as an adiponectin. Adiponectin is a adipokine secreted specifically by the adipose tissue. And in diabetics, adiponectin levels are low. And hypoadiponectinemia is very common, mainly in Asians and Indians. And DPP4 inhibitors are known to increase the adiponectin levels. So by normalizing or improving the adiponectin levels, it has got a more of a effect on the controlling the insulin resistance, anti-inflammatory effects as seen because of the low adiponectin levels. The decreased adiponectin level is a very important pathophysiology and a marker for development of type 2 diabetes mellitus. So it has many studies have shown that DPP4 inhibitors are known to improve the adiponectin levels, and this hypoadiponectemia is seen mainly in Asians and Koreans. So it has been found that patients who are having increased insulin resistance because of adiponectin levels, they definitely respond better to DPP4 inhibitors. There are various other postulations also, like Indians are supposed to have a low beta cell mass and low beta 1 activity. This is also increased because DPP4 inhibitors are known to preserve the beta cell mass and improve the beta secretory effects, which are reduced in the Asians more as compared to Caucasians. So DPP4 inhibitors are definitely more useful in Indian and Asian patients as compared to the Europeans. Over to you, Arvind.
Perfect. So, Dr. Patil sir, knowing the Indian situation about DPP4 inhibitor, how we should practically think about starting a second drug after metformin in Indian our situation? What do you think?
Yeah, up till now, still the choice of starting the treatment in diabetes is still first drug is still the metformin. And after metformin, there are multiple options available, including secretagogue or DPP4 inhibitors, and presently the most popular upcoming drugs are SGLT2. And in acute condition or uncontrolled diabetes with symptomatic, to give symptomatic relief, sometimes we start uh, short acting or long acting insulin after metformin also till the crisis is settled down, and then we switch over to oral tablet. But recently, if you see the after metformin, if you want to have a most beautiful drug, which is weight neutral, which there is less chance of hypoglycemia and almost no side effects, especially hypoglycemia and any other side effects like that. So after metformin, in type 2 diabetes, I would still I will prefer second drug to be added is the DPP4 inhibitor, which are very safe, less or no chance of hypoglycemia, no weight gain, and no other side effects. So this is a second choice. And third choice would be present situation. If the patient has got is an obese patient, if there is a associated cardiovascular risk like atherosclerosis, crude atherosclerosis, or person has undergone angiography, angioplasty, if there is a carotid plaque, or he is obese, strong family history, or patient has got a proteinuria and borderline creatinine. In that case, the next option should be SGLT2. And if if next to that, it would be either insulin or secretagogue, a group of drug like glimepiride or gliclazide. So like that, there are number of drugs, but I would prefer number two drug after metformin should be a DPP4 inhibitor. But special conditions like associated cardiovascular risk or kidney problem, I would prefer second drug after metformin should be SGLT2 because of the present studies and all these things. And uh, later on, either insulin or secretagogue like gliclazide or glimepiride. Yeah.
Okay. Dr. Amit, sir just mentioned about studies. Can you just tell us about Verify trial and the results?
Yes, as we all know, we have definitely find that nowadays patients don't respond to monotherapy. We most of our patients require dual therapy. So the Verify trial is a very unique trial wherein they use the combination of metformin and belredictin as a right from the outset of diagnosis of diabetes. So all treatment naive patients were put on a combination of metformin and belredictin rather than waiting for metformin failure. Because we all know now metformin alone does not work in most of our patients, especially if the HbA1c on diagnosis is around 8 or so. So this trial was done to see the efficacy and the glycemic efficacy and the durability of using metformin and vildagliptin combination right at the outset. And it was found that this combination resulted in a relative risk reduction of almost 50%, 53% of primary treatment failure, and almost 58% of secondary failure, like addition of a third drug requirement is also reduced in almost 58% of the patient if we start this combination right at the beginning. Also, the early reduction in HbA1c and improvement in glycemic control helps in achieving the what we call as the legacy effect. So thereby reducing the micro and macrovascular effect. If we are able to bring down the HbA1c faster rather than going step by step like lifestyle modification, then metformin and then vildagliptin. If we choose our patients right from the beginning, treatment naive patients who have an HbA1c of around 8, we know that they are not going to respond just to one drug or some even lifestyle modification. So rather than waiting for a few months or a few years to add on the DPP4 inhibitors, Verify trial has proved that the efficacy of using it right at the outset, and especially using a single pill combination is more efficacious because it improves the compliance. So using this single pill combination of metformin and vildagliptin right at the beginning, it brings about a very good glycemic control and a reduction in the cardiovascular morbidity and mortality.
Right. Thanks. Dr. Kirti, Dr. Amit said about combination of vindagliptin with metformin. Can you suggest combination of vindagliptin with other anti-diabetic drugs also?
Vildagliptin can be safely combined with other sulfonylurea also. It can be combined with insulin also. The UK prospective diabetic study, which enrolled patients newly diagnosed with type 2 diabetes mellitus, found that monotherapy failure increased over time. So additional therapy with other drugs are required. Approximately 50% of the patient by 3 years and 75% by the 9 years. Verify, as Amit said, is the first study to show that a long-term benefit of glycemic durability of an early combination treatment strategy with vildagliptin and metformin compared with current standard of care. Late combination strategy in patients with newly diagnosed type 2 diabetes. Early combination treatment significantly reduce the probability of initial treatment failure, the time to second treatment failure, and the time to treatment failure compared with monotherapy. So vildagliptin can be combined, as Amit said, with metformin, sulfonylurea, insulin, and also, as Dr. Kumar said, with SGLT2.
Perfect. Kumar sir, does vindagliptin have some drug interactions?
Almost nil. It has been used along with all anti-diabetic, oral anti-diabetic like metformin, sulfonylureas, and then even statin group of drugs, antiplatelet drugs. So almost there is no drug-to-drug interaction with any other drug.
That's great. Dr. Tungare, the most important thing for any anti-diabetic drug today is the cardiovascular outcome trials. So,
Yes.
what are the safety markers of vindagliptin cardiovascular?
Right, there are several studies of DPP4 inhibitors, vildagliptin, and the previous ones also, which is very important because when with rosiglitazone, the cardiac mortality was found to be increased. So world over, they decided that any anti-diabetic drug should prove itself that it is a cardiovascular wise a safe drug. So the trials had to be done to demonstrate the cardiovascular safety. So some of the trials I will just enumerate. There was one examine trial with alogliptin, Savor TIMI 53 trial with saxagliptin, TECOS trial with sitagliptin, Vivid trial with vildagliptin, Carmelina trial with linagliptin, Carolina trial with linagliptin. So these are very important trials which have proved that there is a lot of cardiovascular safety. Now with the examined trial alogliptin, there were 5,380 patients. They all had acute coronary syndrome within the last 3 months, and the results were comparable to placebo, and there was no increased cardiac risk. In Savor trial, Savor TB 53 trial, it was saxagliptin, and the number of patients were 16,000, more than 16,000, and 78% had established atherosclerotic cardiovascular disease, and it proved that for the as far as the mortality and the incidence of myocardial infarction and stroke is concerned, there was no increase in any of the parameters, but there was slight increase in the congestive heart failures with saxagliptin. So that's why that particular molecule is lagging behind. But for the other parameters, saxagliptin also proved to be as equal to the placebo. In the TECOS trial, which was on sitagliptin, the number of patients was 14,600 and odd, and all of them had got cardiovascular disease. This trial went on for 3 years, and sitagliptin proved to be very safe when it was compared with the placebo. There was no increased risk of cardiac failure also with sitagliptin. So Vivid trial was vildagliptin 50 milligrams twice a day, and it was a small trial with number of patients only 254, but they all had congestive cardiac failure, and the ejection fraction was less than 40. So it was a very courageous trial. That's why it was a small trial. because with saxagliptin having proved to increase the cardiac failure, they did a study with vildagliptin, 254 patients, all those who had congestive cardiac failure. In fact, it proved better, and HbA decreased by 4.95% in those who were taking vildagliptin over a year, and only 4.33% in those who were taking placebo. So this was certainly non-inferior to placebo, and the study did not show any congestive cardiac failure with vildagliptin. Carmelina was with linagliptin, 6,900 and odd patients. They all had high CV risk. Some of them, rather 74% had chronic kidney disease, and 57% had also heart problems. It was done to prove cardioprotection, but it was proved that it is non-inferior to placebo on the 2.1 year of follow-up. The Carolina is another linagliptin study. It compared linagliptin with glimepiride, and the number of patients was 6,000. The patient with cardiovascular disease was 40%, and very important is linagliptin did not prove to be superior or inferior to glimepiride. So in fact, this Carolina study has proved cardiovascular safety of sulfonylureas. And again, the glimepiride has come into the market. So we are happy that the DPP4s, which are very important drugs for us, are very relatively safe for the cardiovascular system also. Over to her.
Right. In fact, my internet connection is little poor, so I may miss in between. So I will ask two questions together. One to Dr. Kirti Mistry about reservation of vildagliptin as in cases of ASCVD, and the next would be to Dr. Amit about the renal safety. If my connection just loses, probably you take one after the other. Dr. Kirti first, about ASCVD patients.
Vildagliptin has many pleomorphic effect also. It improves the endothelial dysfunction in patients with diabetes. It has also antioxidant activity. There is a slight improvement in the lipids also. Also, patient with frank heart failure, I think it should be avoided. But with mild to moderate, I think it can be continued. Yeah. Dr. Tungar.
Okay, no, Dr. Amit, then
Amit.
would you need to modify the dose of vildagliptin with GFR?
Yes, vildagliptin is very safe at all the levels of renal dysfunction. In fact, it can be used even in patients who are on hemodialysis and end-stage renal disease. But of course, with the caveat that we have to reduce the dose. The reduction in dose is required because the main elimination route of vildagliptin and its metabolite is through the kidneys. So there is an increased accumulation of the drug. So not because of any nephrotoxicity, but because the job which was done by 2 tablets of vildagliptin can be done by 1 tablet because of the prolonged availability of the drug because of reduced excretion. So by reducing the dose to half the dose that is normally prescribed, like say once a day dose, we can even use vildagliptin right up to the end-stage renal disease without any significant side effect, and it brings about a very good glycemic control. So no problems regarding hypoglycemia, etc., which is very commonly seen in these patients of renal dysfunction. So vildagliptin is safe because it proves that it doesn't reduce the blood sugar level unless the blood sugars are very high, because it has got an effect on the glucagon also. So if the blood glucose goes down, it can increase the glucagon levels, thereby preventing hypoglycemia. So use of vildagliptin is very good in all stages of renal dysfunction.
Perfect.
But of course, we have to reduce the dose to 50% to avoid hypoglycemia, because the availability of the drug is more. No nephrotoxicity is known. In fact, vildagliptin has found to have some nephroprotective effect also. Of course, there are very few studies, but in some patients, especially with it is known to cause reduction in the urinary albumin creatine ratio, especially patients who have macroalbuminuria. The effect and the efficacy in patients with microalbuminuria is limited, but patients who have macroalbuminuria, definitely vildagliptin reduces the albumin secretion, and definitely it has got a good nephroprotective effect. In fact, the DPP4 receptors show highest expression in the kidneys as compared to all the other organs. So DPP4 inhibitors act in the kidney by upregulation of the renal cyclic AMP production, which brings about an antioxidant and an anti-inflammatory benefit. So by that way it can produce the nephroprotective effect. So the DPP4 inhibitors have an anti-apoptotic, immunologic, and antioxidant beneficial effect in patients with renal dysfunction. Thereby, it can be definitely used. But of course, with a reduction in dose, if the renal eGFR is less than 50%, you reduce the dose by 50%.
Yeah. So, Dr. Tungar, knowing the renoprotective effect of Vindagliptin, how do you place Vindagliptin in different stages of diabetic nephropathy?
Amit has already told us
told it.
everything
Yeah,
about
yeah.
it, but still I will just reiterate whatever he has said. It is very interesting because 85% of vildagliptin is excreted in the urine by the kidneys, and still it can be used in CKD. That is the important thing, because whatever the reason, active metabolite is M20.7, which is amino group hydrolysis, and it is vildagliptin is not metabolized by cytochrome P450. That's why there are no cross reactions with other medications. 22% of vildagliptin is excreted unchanged in feces, and then there are certain very few minor metabolites. So that is the very interesting thing, and the renoprotective action is impressive. Amit has already told us about that. So below eGFR of 50% to 30%, we can use 50 milligram once a day. I think below 30% eGFR, then it should be avoided.
It can be used. 25 milligram can be used.
Even in who are on dialysis, 25 milligram can be used.
You can use 25 milligram once a day.
In dialysis patients also, you have to adjust the time of the dialysis, and the nephrologists do a wonderful job on that. So it can be used even in patients who are on dialysis.
Dr. Kumar, another fear of any drug that we use is age. How do you place Vindagliptin for elderly patients?
Yeah, this vildagliptin is very, very safe in elderly because the blood sugar control is very smooth. So, and there is no chance of hypoglycemia. This is always preservation of beta cells with all this DPP4, and there are no other side effects on blood pressure. There is no cardiac arrhythmias because of DPP4 or vildagliptin, and there is no effect on bone metabolism also. So for elderly people, along with metformin, vildagliptin is very, very safe. But in case if you are using secretagogue like other drug, then you have to monitor sugar and see whether patient is developing hypoglycemia. But per se, vildagliptin doesn't give rise to hypoglycemia and no arrhythmia, so it is quite safe in elderly patients.
That's very encouraging, sir. So, Dr. Kirti, another caveat of using Vindagliptin in hepatic dysfunction. How do you place Vindagliptin there?
Vildagliptin can be safely used in a patient with hepatic disorder. Even it can be used in the cirrhosis of liver also. The care should be taken when it is combined with sulfonylurea. You have to be careful because there are chances of hypoglycemia. Only one case was reported where after giving vildagliptin, there was a idiosyncratic reaction. This was reported in a 65-year-old lady who was given vildagliptin. She had an acute rise in the hepatic enzymes. So when she was changed over to linagliptin, she settled down. So using vildagliptin in a hepatic disorder, I think it is safe. Only the care should be taken when it is combined with other hypoglycemic agents.
Perfect. So now we have come to a conclusion that probably all the risk factors and threat cases of cardiac, renal, hepatic that we are safe with even in elderly age. So Vindagliptin scores over and we are confident using that. Another important point was that recently when Vindagliptin got off patent, after that the costs had come down. So I'm supposed to be asking every one of you your view on Vindagliptin in the post patent area, when the patent has been lost and many companies have come with their products with a reasonable cost to Vindagliptin. Will that benefit the patients and the use of Vindagliptin as in whole for diabetic patients? We'll start with Dr. Amit.
Yeah, definitely, it's a wonderful thing for the patients. Our Indian patients are going to be benefited tremendously because Indians are very cost sensitive. So even if the best drug is available, but if it is highly priced, then definitely they have a reluctance to continue for a long period. So with the reduction in the dose at the off-patent status, the patients will continue to stick to vildagliptin if we write it, and they will have a good beneficial. However, we should see the efficacy and the bioavailability of the drugs are maintained properly. So then, of course, it's a wonderful news for our Indian diabetic patients.
Dr. Kirti, what do you say?
After the price reduction, the use of vildagliptin has increased. Even we have started using vildagliptin in a poor patient also, poor diabetic patient also we have started. I think that is a good point after the price reduction. So more and more patients are benefited.
Patients would come. That's very nice. Dr. Rajiv now?
Most of our patients are on multiple medicines. That's why the cost matters a lot. It's very important. And it was prohibitively expensive.
Yeah.
And now the benefit of this wonderful drug can reach to the poorest of the poor. And I'm very happy about it. Initially, I had a lot of reluctance when DPP4 came. I had reluctance in using. When the gliflozins came, I had reluctance to use.
No,
But slowly and
probably,
slowly, we are getting used to reduction in.
yeah, in fact, that is our cautious
Yeah.
approach for any new drug to come with.
Yes. Yeah.
And then the
Yes.
cost. And probably now we are sure about it. Dr. Kumar, do you think
Yes.
of all such newcomers are same?
All new, yeah, I couldn't hear you. Yeah,
Please repeat
Yeah,
your
when it has got off, when
Off patent.
Vindagliptin got off patent, so many
Yeah, yeah.
companies have come with their brands. So you think all are
Yes,
same?
so many. No.
Yeah,
You
So
have to
almost-
choose your
almost all
company and you have to be sure about the branding.
Sure
That
about
is
it.
very
Yeah,
important.
that
It's
is
not a very
that is
simple
important.
molecule. It's a very complex molecule. Although it's not
No,
a
but-
big molecule, it's a small
No,
molecule,
but,
but the making
Raju-
is very important.
Raju, one thing you understand, the production is done at one particular, and you
Ah.
ask your brand name, they will get you at your
Random,
doorstep.
maybe.
So
they
the
do
quality,
from
I
same.
think quality we have to trust
We have
and
to trust
we have
from
to
them.
believe.
Yeah, yeah.
Use
You
all
have
this
to know. You have to
company.
see that it is coming from a good reputed pharmaceutical
Reliable source.
company. Otherwise, we
That-
have seen duplicate medications in
Oh,
everywhere in India.
that our Indian, you know,
even in the
Glaxo
generics,
products are also
Modi medicine also
manufactured.
vildagliptin is available.
Glaxo products are also
Yeah.
manufactured somewhere in the suburb, not in their
Arey,
home.
no, but if Glaxo says that this is the Glaxo product, you know that they have done the required tests.
No, I-
Very
I-
controlled.
Let them manufacture anywhere. Let them manufacture, but then the guarantee of the quality is to be taken by somebody who has
I
very
don't know.
respect in
Everything is
in
very
this.
much commercialized.
I wouldn't believe any generic today's patients. The one patient shifted from general medicine from branded medicine to generic medicine. Sugars were totally haywire.
Yeah,
So I
see,
said,
when-
now don't do anything. Just switch over to previous brand and we will see.
I told them if you want to take generic all, I tell always to a patient, Amir Khan doesn't stay in Bandra East. He always stay at Pali Hill. And talk of nonsense, all these things. So if you can afford, you please buy this medicine.
Yeah. And
Otherwise,
at the
cheaper.
same time, to very poor people, we are very
I
considerate.
specifically
We
tell
try
them.
to monitor them.
Yeah.
We try to help
Yeah,
them with samples and whatnot. So it's not that if we ask for branded medicine, then we are cheating them or anything. Nothing like that. We have to see that. Suppose a patient's sugars are very high and unstable. We will tell them, Baba, शुरू में अभी थोड़े दिन तक branded ले लो. Once the sugars are normal, and I think it is with all of us.
Yes.
When the sugars are normal, we will see. We will
The
give
sugar
you. I think we all do.
medicine is working.
But with vildagliptin becoming a brand by good pharma companies, I am very happy. The patient doesn't have to go for the generic medicine, which we don't know the quality.
So So
What
the
is your
conclusion,
experience
Yeah.
with the long?
Yeah.
Arvind, what is your experience with the long-acting vildagliptin now?
Not used. I have not used so far.
yeah, I have
It
used.
is
I have
very
used.
good. I
OD
used it.
dose,
It's a good
very
result.
good, very
OD
good.
dose.
See,
Good
I
results.
the
Sitagliptin was already available in the market. No,
see
sitagliptin was
the
already
effect is like 2 doses earlier, and it is a very the OD dose
but
formulation I have used left and
we
right.
have to use metformin minimum 2 times. So there is no
Right, right.
big advantage on that.
So no,
If
no,
you are
sir,
most of the time, 99% of the time, you are using
So
metformin.
you don't give metformin only once a day. Metformin always you give twice a day. That is a good
no,
point.
sir,
So
but
most
metformin
No,
as
no,
such
metformin
is
sustained release you can give once a day, no? Why do you require twice a day?
How do you give
that
1,500 milligram once a day?
if you want
No,
to
no.
give
No,
1 gram
why do you want to
metformin,
give 1,500? Our Indians
I
do not
give 2,000.
You 850 BD, na?
see
give
usually it
850.
is combined
Give
with
1,000 milligram OD
some other
also is good
drugs.
enough, I feel. I
and
have
the
shown
side
good
of the
Nah,
results.
1,000
tablet and
OD.
all, I think
No difference in
metformin is quite
1,500
good
and
combination.
1,000, I think. Most of the patients don't tolerate only. If you put 1,500, they
Then
don't
I
tolerate only.
1,500. I mean 1,500 is easily tolerable. SR preparation. They,
See,
You have to use now single once a day dose.
okay,
Available
so
है.
I
so
don't.
to
1,000 के ऊपर मैंने
conclude,
अभी तक दिया नहीं किसी को more than
मैंने भी 1,000
once.
के ऊपर दिया ही नहीं है.
yeah, so to
1,000,
conclude, apart from
1,000.
the
Yeah.
minor points that we have differences, that we have concluded that probably there is a question to you, how to choose between various gliptins in a diabetic. Now they are wanting us to any one of you take up this different gliptins one over the other. Whether Winda can score over the others, you think so? Because telegliptin came just before with a lesser cost and was a competitor. Now, how you put new after off patent Vindagliptin with teneligliptin or others? Anybody? Amit?
The vildagliptin can be used in most of the patients. Of course, we like to see that the efficacy is maintained. Some patients require only once a day. So now the OD preparation is available. The previously we used to go for teneligliptin or linagliptin, which is once a day. Some patients we do not want to reduce the dose. Like say, even 30 milligram GEGFR is less than 30 milligram, we can safely use linagliptin without any dose reduction. Which of course here we require a dose reduction. So these are few points as we can see. Otherwise, there is no difference between the efficacy of the glycemic efficacy and most of the gliptins. We can safely use, of course, with heart failure patients, we should try and restrict patients to use the drugs which have got a specific availability of the data. Like say we should not use hexagliptin or alogliptin if patients have incidence of heart failure or previous history or an acute heart failure. Then we can use other drugs who have got a CV safety data available. That is very important.
Perfect. So I think we have summarized quite a few points to clear up all the doubts about Vindagliptin. So I think I should hand it over to Mandar. Mandar, are you there?
Yes, sir. Can we conclude now?
Yes.
Yes.
We have already concluded.
Yeah, so I think we had a wonderful discussion. Dr. Arvind Gongane has moderated it extremely well. And I think Dr. Amit Trivedi pointed out, a very important point, that we had a perception all these years that linagliptin is the only gliptin which can be used in the renal impairment and other gliptins cannot be. But I think all gliptins can be used in the renal impairment, of course, with the proper dosages. That was a very important point made by Dr. Amit Trivedi. And of course, we had a little point of difference among the panelists among the use of 100 milligrams of vildagliptin, which has come recently. But I think with time, only time will prove it, because India, as everybody said, is a very price sensitive market. And although right now 100 milligrams of vildagliptin does not have very big trial, but I think all of us will agree with, I think all panelists will agree with me, including Dr. Arvind Gongane, who is our moderator, that Indian patients deserve to have a chance with 100 milligrams of vildagliptin, because one, vildagliptin all these years was a twice a day molecule. In fact, it was the only gliptin which was twice a day. All other gliptins were once a day. And with this introduction, now you can give vildagliptin as a once a day dosage. And of course, there is a price benefit because the vildagliptin 100 milligrams has been introduced at a very, very economical cost. In fact, Alkem has also introduced vildagliptin 100 milligrams, and Gluvilda OD 100 is available at one of the most economical price of 10 rupees per tablet. And it is the most economical brand among all the vildagliptin 100 milligrams molecule, as Gluvilda OD 100 is available at just 10 rupees a tablet. So with this few words, I sincerely thank Dr. Arvind Gongani, who has moderated the session so very beautifully, and all our other panelists, Dr. Amit Trivedi, Dr. Shruti Mistry, Dr. Kumar Patil, and Dr. Rajiv Tungare for having joined us today evening for Views Vildagliptin panel discussion. Once again, thank you very much and good night.
Thank you.
Thank you.
Good night, everybody.
Bye.
Good night.
Thank you, sir.